Welcome to the Epilepsy Foundation's webinar on how to best prepare for pregnancy, sponsored by UCB for National Epilepsy Awareness Month. I'm Allison Kukla, the Senior Manager for Programs and Partnerships here at the Foundation, and I'll be your moderator this afternoon. We are so grateful to the speakers who are here with us and all of you who are joining us today for this webinar on this very important topic. Epilepsy is one of the most common medical conditions in women of reproductive age. While most women with epilepsy can and do have normal pregnancies, there are some unique considerations to keep in mind. During this webinar, you will hear from experts who will share tips and strategies to lessen risks and promote good outcome for mother and baby. I am pleased to have with me Dr. Allison Pack, Monique Hopgood-Willis, Dr. Patricia Penovich, and Dr. Elizabeth Gerard as our experts for this conversation. I'm going to start by introducing all of them real quick, and then we'll dive into our conversation. I'll start with Dr. Allison Pack. She is a professor of neurology at Columbia University Irvine Medical Center, New York Presbyterian Hospital, and chief of the Epilepsy and Sleep Division. Her research has focused on effects of anti-seizure medications on bone and mineral metabolism, as well as the care of persons of childbearing potential with epilepsy, including studies among pregnant persons with epilepsy and contraceptive practices in persons of childbearing potential with epilepsy. She serves as the chair of the Professional Advisory Board of the Epilepsy Foundation. Welcome, Dr. Pack. Monique Hopgood-Willis is a fighter who refuses to let adversity define her. After surviving bacterial meningitis that resulted in epilepsy and cognitive impairments, she continues to live life to the fullest as a dedicated wife, loving mother, and passionate neuroscience student entering her 4th year of studies. She is committed to helping others be educated in neurological diseases and helping people take charge of their health. Monique shares her medical knowledge and personal triumphs with warmth and wisdom. By detailing her own story of thriving adversity, Monique motivates women to tap into their inner strength. She provides an inspirational perspective and encourages women to see each other's obstacle as an opportunity for growth. Welcome, Monique. Dr. Patricia Penovich is a board-certified adult epileptologist. She's practiced and is now emeritus at the Minnesota Epilepsy Group in St. Paul, Minnesota, where she developed her interests in treating women with epilepsy and served as the site PI for the NEED and MONEED studies. She also serves on the National Epilepsy Foundation Professional Advisory Board and is chair of the Professional Advisory Board at the Epilepsy Foundation of Minnesota. Welcome, Dr. Penovich. And last but not least, we have Dr. Elizabeth Gerard. She's the Associate Professor of Neurology at Northwestern University's Feinberg School of Medicine and an epileptologist and clinical neurophysiologist at Northwestern Medicine. She's the founding director of the Women with Epilepsy program at Northwestern and co-director of the Translational Adult Epilepsy Genetics program. Dr. Gerard's clinical and academic interests include providing expert epilepsy care to persons with epilepsy who are assigned female at birth. She has been fortunate to be involved in the MONEED study, serving as the principal investigator at Northwestern. Welcome, Dr. Gerard. As you can see, we have a group of experts here to talk about this very important topic. So thank you all for being here, and I'm excited to get this conversation started. So as a reminder, please put any questions you have throughout the conversation in the Q&A box, and we'll get those questions answered throughout the conversation. So I'm going to start with Dr. Pack. Working together with your doctors will set you on a course to have a safe and healthy pregnancy. Why is it important for women with epilepsy to plan their pregnancy when possible?
Thank you, Allison, and thanks to all of you for this invitation to this really important webinar. So really, if you think about it, any pregnancy, the outcome of any pregnancy is improved if it's planned. But for individuals with epilepsy, this is particularly important. And I'm going to focus on 3 specific areas. One is seizure control. Generalized tonic-clonic seizures, or what we call focal to bilateral tonic-clonic seizures, are associated with negative outcomes both for the mother as well as the developing child. It is therefore important to get those under control prior to conception. So seizure control is important. Number two, the anti-seizure medications that the individual is being treated with. Some medications are associated with more negative outcomes. Notably, valproic acid is associated with increased risk of major congenital malformations, as well as adverse neurodevelopmental outcomes. Therefore, if an individual is on this medication, that needs to be addressed prior to conception. There are some medications that have more beneficial profiles. One might want to consider being treated with one of those medications. And the third reason is folic acid. The folic acid story is evolving and challenging, but what we do know is that folic acid supplementation prior to conception improves outcomes. We know in the general population that folic acid supplementation, since it was enriched in grains and cereals and breads, actually we saw a reduction in major congenital malformations, notably neural tube defects. That's in the general population. We've not been able to prove in studies that folic acid supplementations in individuals with epilepsy reduces the risk of major congenital malformations. However, it is important that individuals are given folic acid supplementation to optimize that environment. One particular area that's important for folic acid supplementation is neurodevelopmental outcomes. In studies, such as in prospective studies whereby women or individuals with epilepsy were followed and then they followed the outcomes in children, we were able to see that the mothers who took folic acid supplementation, when you followed their children, the children whose mothers took folic acid supplementation did better in neurodevelopmental outcomes when compared to those who didn't. Studies also find folic acid supplementation being associated with reduced risk of autistic spectrum disorders. So for those three reasons, pregnancy planning is very important for individuals with epilepsy.
Thank you. That was all very helpful. And I know when I went through my pregnancy journey, we talked about folic acid a lot. So thank you for covering that so in depth. And Dr. Gerard, I'd like to come to you next as a follow-up to a lot of what Dr. Pack was saying. What are some of the first things women with epilepsy can do as they start to plan their pregnancy journey? And what are some questions they should ask their doctor when coming to start their pregnancy journey? Oh, you're muted, Dr. Gerard.
I apologize. Sorry, I was just saying thank you for inviting me and putting this together. What an important real symposium and webinar. So to answer your question, I'm going to echo a lot of the things that Dr. Pack said, but I think the first thing a patient can do is really make sure that they're informed and that they inform themselves and plan for their pregnancy as far in advance as possible. I mean, you want to talk about this even if you just found out you're pregnant, but the earlier you can plan your pregnancy, the more you can make sure you're prepared and you have a good understanding that you've done everything that you can to optimize the outcomes of the pregnancy. So I think the first question we just heard about is to ask, am I on the best medications for me and my pregnancy? So what we want for all patients planning pregnancy is that they are on the best medication that controls their seizures at the lowest possible dose. And we do try to avoid those medications that are known to be higher risk in pregnancy and for the fetus, like valproic acid, whenever we can. But regardless of the medication that you're taking, we want to make sure that it works for you and that it's at the lowest possible dose that you need. So I think another really important thing to plan with your doctor prior to pregnancy is, am I on the lowest dose that I need of this medication for pregnancy? And that usually corresponds to blood levels. So we'll talk today a lot about the relationship between medication doses and blood levels, but we more and more follow blood levels during pregnancy. So there's not any one specific level that you need for pregnancy, like that all patients need or all individuals need, but you need the level that's best works for your seizures, and can be followed during pregnancy. We know that blood levels can change and lower during pregnancy, and we're going to be optimizing your medication doses during pregnancy to maintain the level that works for you. But you want to start low. You want to start low, that at a low level that works for you. And this becomes an example of where this becomes important, for example, is if you're on birth control pills as well as a medication like lamotrigine. We know birth control pills lower levels of lamotrigine for most individuals taking the two medications together. And so if you're stopping birth control pills prior to getting pregnant, your lamotrigine levels will go up. So it's really important to ask your doctor if that can be adjusted, and if you know what level works for you, so you can make sure you're there prior to pregnancy. Other things you want to ask about are how are you going to be followed during pregnancy? What's the plan for following your medication levels? How are you going to be followed by your obstetrician? And is there an obstetrician that your doctor recommends? Do they work well together? Can they connect with each other? And then lastly, about folic acid, you want to start folic acid prior to planning pregnancy, and talk to your doctor about what's the dose that they recommend for you.
Thank you. All very helpful tips. I feel like we can have a checklist put together with all of that for women with epilepsy. That would be extremely helpful. Monique, I want to come to you because we know the lived experience is so important to share on, webinars. So as a woman with epilepsy who has had a successful pregnancy, can you tell us what was most beneficial to you during your journey?
Thank you for having me and inviting me for this webinar. I actually, and this is what I did. I was actually, everything the doctors just said was not planned. I was married, but it was not planned. Therefore, it was kind of a scramble together with my doctors to put a plan together. I was also only 22 years old, so I was not really even thinking about epilepsy and pregnancy going hand in hand. But once we kind of got to the planning part of it, I reduced a lot of my stress levels. That is a trigger for my epilepsy and my seizures. So it was actually a blessing in disguise because I had got laid off from my job right when I found out they had took away my position and was making some changes in the company. And so I was like, cool, now this time I can take my time and actually relax and be stress-free and start planning to be a mom in this pregnancy journey. I did a lot of stress-free activities, a lot of mind-numbing TV, and a lot of exercise. I was pregnant in July, so I went swimming. Here in Atlanta, it gets very hot. So I went swimming, did a lot of walks, and just did a lot of stress-free things to make sure that I did not have a seizure, because I wanted to be as healthy as possible for myself and for my baby. I remember my dad telling me, please just be as stressed possible. We want to have a healthy granddaughter. So I definitely think whatever your triggers are, try to make sure you know what your triggers are and help try to navigate that the best you know how.
Thank you. And that was a very, important point, knowing what your triggers are and how you can manage those. And, we'll touch upon, kind of that question later, an unplanned pregnancy and how to handle that. I want to come to Dr. Gerard real quick because a question came in while she was talking, and I know she wants to answer it live here. What is the safest, most recommended medication for pregnancy? I know we talked about some already, so if you can answer that for our attendee.
So the two medications that we have the most evidence in support of them being relatively low risk in pregnancy are lamotrigine and levetiracetam. So many of the experts on this panel and other experts, if they're first starting a patient on medication for epilepsy who might consider a pregnancy in the future, they'll likely start with lamotrigine or levetiracetam, or either the combination of them too. Similarly, if a patient comes on a higher risk medication or a medication that we don't know that much about, we might consider switching them to one of those medications. But it's important to say that if those medications have been tried and not worked, there are still other medications that we can use safely in pregnancy, or we can at least counsel on the risks and benefits.
Thank you for that response. Dr. Panovich, was going to come to you next. We didn't forget about you. Don't worry. So it's common to make a birth plan.
I think she had a.
Or did
I
you
think
want
Dr. Penovich.
Did you want to follow up on that question that came in? Oh,
You're
muted, Dr. Penovich.
Sorry, I wanted to make a comment to Elizabeth's and Allison's talk, which are superb, which is, if at all possible, you want to make this planning ahead, really way ahead, because most pregnancies, 55% of them are unplanned. So it could be like Monique said, that, oops, you know, it's happened and you haven't thought about it. So, and staying seizure free, as Elizabeth said, is really important. And the best way to sort of know how you're going to respond during your pregnancy is what you do for the 9 months beforehand. You were seizure free then, super. You were not seizure free then you're maybe at a much higher risk to have troubles during pregnancy, in part because levels may change. And Elizabeth, I think you'll agree with me as well that if you need to be changing your medicine, you want to do that well ahead of being pregnant, if at all possible.
Thank you for that input. And then I want to have a question for you. It's common to make a birth plan when you're planning pregnancy. How can someone work to make a birth plan with their doctors to have a safe and healthy pregnancy while also managing their epilepsy?
I think we all like to think we're going to keep our cool during labor and delivery, and then any of us who've gone through it know that there are times you certainly don't do that. So having your birth plan, which is sort of your wishes for how you want your labor to go, your delivery to go, your postpartum care and your newborn care to go, all well outlined, so you don't have to think, just push, etc. during the delivery. So even though we talk about things that could go wrong in a delivery, you have to remember that about 90% of deliveries are normal and 90% of all those pregnancies are normal. So the likelihood, even if we talk about things that could happen, the likelihood is that you're going to do just fine and your baby's going to do just fine as well. So we think about the birth plan as kind of following the Girl Scout model of be prepared, at least it was when I was a Girl Scout. So you're going to put down all of the ideal situations that you may have out there, and then the what ifs. So what if I have a seizure during pregnancy, or what if I have to have a cesarean section, will be part of that plan as well. You sort of thought ahead, say, what could I do? And you want to do this in conjunction with your significant other and your physician. So part of that may involve your epilepsy physician as well as your obstetrician. And then when you have that plan sort of developed, you've had time to think about it, have copies made. So you have one, your significant other has one, and when you both forget where you put it, there's one in your suitcase that's going to the hospital, one in your hospital or office chart as well. So they're sprinkled around, so nobody can say they don't have access to it. So obviously you want to stay seizure free. So part of that birth plan, and Monique said that very well about stress. I mean, delivery is kind of a stressful as well as a happy situation, but it could be a time when a seizure comes out. Probably less than 2% of patients will have seizures during delivery, labor and delivery. So again, the likelihood is that this is not going to happen, but you want to be prepared for that. So it would probably be, and particularly if you've had seizures in your pregnancy or at a higher risk to have seizures because you had them before, you might want to have a heparin lock or a saline lock in your arm, so if medication needs to be given emergently, it's there already, or an IV situation in place. If labor is going on for a long period of time, you want to have kind of an outline about when your next regular dose should be. Or if things are getting a little bit more hectic, should you have an extra dose of medicine? And that's where your epilepsy physician should weigh in. Do you need a rescue medicine? Should you start to feel you're having an aura or a warning, or you're feeling like something could happen? That would be an important thing to be part of your birth plan. Labor can be long, particularly if it's your first one. It can be very short if it's that second or third one. But if it's long, you're going to want to take time to rest and to sleep, and if at all possible, so that you avoid that sleep deprivation stress phenomenon that Monique talked about as well. And then if you happen to have a C-section, you should be sort of clear in your birth plan about what kind of anesthetic, epidural or pudendal or whatever you're going to have. And that's a discussion with your obstetrician as to what would be appropriate for you. Who's going to be there with you should you need a C-section? Is that person going to be the person who's going to hold the baby after delivery, etc.? The other thing that happens not long after delivery is that medication levels will change fairly quickly, particularly for some of the medications, which if you had your levels increased or your doses increased during your pregnancy, all of a sudden you won't need that much and you don't want to get toxic. So it might be you need some adjustment not long after delivery so that your doses go down. Different medicines sort of have different times when that may happen. So your epilepsy physician may say they want a level checked within 24 hours or 3 days or 5 days or whatever. So that part of participation in the plan is important. Let's see, I think part of the birth plan should also be a note to yourself, perhaps, as to making sure that you've got a post-delivery appointment to see your epilepsy physician as well. And I'm not sure we actually have sort of slated to talk about this, but part of thinking about having that baby and coming right home early on is how you function at home to have a safe baby at home in those first few days. It's a chaotic time, totally chaotic. You're not going to sleep. That baby's going to sleep at times when you are not sleeping and vice versa. So what can be helpful is to have somebody else there who's going to help you out for sure. Now is not the time to think you're going to start cooking again or cleaning the house. I suggest you ask your mom or your in-laws to help you out with that, or have your friends give you a month's supply of food, delivery service or diaper service or whatever, so that those pressures are kind of off as well. And then the usual things about having somebody with you when you bathe the baby, not having the baby in the bathtub, very common sense kinds of things, not having the baby up on a high level when you're changing them in case a seizure would happen. So that's a not so quick, but a few things to think about.
No, didn't think that would be quick. You know, putting seizure action plans together aren't necessarily quick. So putting a birth plan together probably wouldn't be quick either, but those are all definitely helpful tips. We got some questions that came in too. So I'm going to bring one to you real quick because you kind of covered this. So I just wanted to clarify it for the audience. Is there a preference for a vaginal delivery or C-section for women with epilepsy? I know you kind of talked about the differences between both with a birth plan.
I think a lot of this is a discussion between you and your OB. If you've had a prior C-section, you might need to have another C-section. If there's some concern about baby size or something, you might need a C-section, but there's no reason why you have to have a C-section. And I think when we looked at the data from the Moniques studies, the rate of C-sections for moms with epilepsy and the general population of women who were pregnant were essentially the same.
Okay. Thank you. Now we're going to go back to Dr. Peck. So women with epilepsy, like we talked about, have a number of unique concerns during pregnancy. Can you tell us about some of those concerns?
There's definitely some concerns, and some of what we'll touch upon we may end up repeating, but I don't know about you guys. Repetition has always been good for me. So one is seizure control. And I think we're going to talk about that a little bit more in detail later about how you maintain seizure control. But keep in mind, most individuals do maintain seizure control. And Dr. Panovich spoke earlier about the biggest predictor of that is being in the 9 months prior to getting pregnant. The other is the effects on the developing fetus. What's happening with my baby? Is my baby going to be okay? And, we touched a little bit upon safe drugs and not safe drugs. And I thought I would just take a few minutes just describing, you know, we throw around this term major congenital malformations. Well, what do we mean by that? What does that mean? And that is one of the risks that we think about. It's one of the risks that has been the most studied through international registries, an amazing effort by the epilepsy community trying to understand that. Well, what we mean by major congenital malformations are physical malformations that either interfere with the function of the child or require surgery. And it's important to recognize that the risk in the general population is about 2 to 3%. And so you worry then, is my baby going to be, is it higher risk? And as we've touched upon, there are some medications associated with higher risks. And then, you know, Dr. Gerard went through very nicely that some of our medications are associated with lower risks, notably lamotrigine and levetiracetam. And I saw a question in the chat that I'm going to address along this topic. So somebody asked a question about which combines those two factors, right? The seizure control as well as the risk of major congenital malformations. And so in the chat, in the question and answer, there was a question about that person, about an individual whose seizures, after much trial and error, are best controlled on a combination of valproic acid and lamotrigine. And when you read all of the literature, when you look at it, and if that is your combination that works for you, you walk away with a very ill feeling, like, am I going to have a healthy baby? And so certainly we try to avoid valproic acid, but I have to say I've taken care, as I know Dr. Panovich and Gerard have, individuals whereby the only medication that controls their seizures is valproic acid. And so does that mean that individual can never get pregnant? And I understand the concern about seizure control, because we talked already about how seizures, particularly convulsive seizures, are associated with risks to the mother and the child. And so one of the caveats with valproic acid is really, the big caveat is the dose. And so if I have an individual, such as a question that has, for example, juvenile myoclonic epilepsy, I lower the dose as much as possible, controlling the convulsive seizures. I may live, so to speak, with that individual. I'm not the one living it, but the individual I'm treating with some more myoclonus, because there's no clear data, for example, to support that myoclonus can have negative effects on that developing fetus. And so lower the dose as much as possible. The critical dose that you see in the studies is 750 milligrams. Levels around 40. So that's one of the caveats that I do recommend, because I think that question really raises those unique concerns, seizure control and effects on the developing fetus. The other is, so those are the major congenital malformations. Then I touched upon, in the last time I spoke, a little bit on neurodevelopmental outcomes. Well, what do we mean by that? Is my baby going to have the IQ he, she, they would have had if I didn't have epilepsy and I wasn't taking anti-seizure medications? And so there are studies that have looked at that. And overall, again, the one medication, and again, this is associated with the potential negative effect there, is also valproic acid. And in going along what we discussed earlier, lower the dose if that medication is the one that is necessary to control. Because we also know that when you look at neurodevelopmental outcomes, and I would say no is probably a little bit of a strong statement there. There is an older study suggesting that if the mother had multiple convulsive seizures, that may also have a negative effect on neurocognitive outcomes as well. Dr. Panovich, the other thing is delivery. We did a very nice overview of that just now. And then the final thing of the unique concerns is, can I breastfeed? And so for many of the individual, we recommend breastfeeding. And Dr. Gerard, hats off to her, just has a publication coming out in this area and did a really nice analysis. And what we know in studies and looking, example, at cognitive outcomes is that if anything, actually, the mothers or the individuals who breastfed their children were actually more likely to do better on cognitive outcomes. So the answer to that is yes, that you can breastfeed. So those are some of the unique concerns that I was thinking about, and that I address with the individuals that I treat during pregnancy. And again, a lot of that's guided by the questions patients I've treated over the years have asked me.
Thank you. And I would agree, we're going to repeat a lot of the stuff, but repetition is good. So I wanted to go to Dr. Gerard with kind of a similar ask. You know, we just heard about some of the unique concerns to keep in mind. What tips would you have for our listeners to best address those concerns? You know, for example, how can someone best keep their seizures under control while pregnant, or, you know, addressing any of the other unique concerns that Dr. Pack just so, you know, beautifully went over?
Yeah, I mean, she covered so much, and I think I'm going to start by talking a little bit about keeping your seizures under control while pregnant, that you asked about, and then I know we have a lot of questions in the chat as well. I might touch on a few things, but I think important. Dr. Penovich talked about how seizure control prior to pregnancy is usually the best indication of seizure control during pregnancy, and there's even a new publication going out that, contrary to kind of a lot of things people used to think, pregnancy itself is not likely to make your seizures worse. People worry about that. But in general, seizure control stays about stable during pregnancy, with one caveat. And that caveat is seizure control stays stable if we are monitoring and adjusting your seizure medications. Because for many of our seizure medications, we know this best for lamotrigine, but we also know it to be true for levetiracetam. It's also true for several other medications. Your blood levels of that medication may go down even if you're taking the same dose and taking it perfectly. These kind of changes in how your body metabolizes the medication during pregnancy can start even at 4 or 6 weeks of pregnancy, and you start to burn up that medication faster. So both your brain and your baby are seeing less of it throughout pregnancy. So it's really important to work with your doctor. Most of us monitor medication levels about monthly during pregnancy. It may be a little bit less or a little bit longer, depending on the individual. And then we prior to pregnancy have set a target goal level that I was referring to earlier about, hey, this is the level we want to maintain for your pregnancy and for your seizure control. And we try to maintain that or close to that level throughout pregnancy. One important thing is it's important you get those levels at a time that's convenient for you and that's consistent. Because if you get one level before you take your medications in the morning and one at 4 o'clock in the afternoon, it's going to be very hard for your doctor to compare those two levels. So it's best that you take those levels at the same time of day, starting once or twice prior to getting pregnant, and then during your pregnancy. And that can help us maintain your seizure control during pregnancy. The other things are things Dr. Penovich talked about, obviously taking your medications regularly, using some form of a pill box to stay on top of your medications. I did see a question in the chat about how to take your medications. Most people can take their medications the same way they would when they're not pregnant, including during labor. You would take those medications as best you can on schedule. And if you aren't able to tolerate them by mouth, they may have them intravenously during pregnancy, but during labor, you want to keep your schedule the same as you would at home. If anything, err on taking a little bit more. And then I heard from Monique, thanks for sharing, that stress is a big trigger. And so obviously pregnancy can be a stressful time for many, many reasons. So making sure you have your support team in place, making sure that may include a therapist. Even if you're feeling great, it's often very good idea to have a support team or therapist during pregnancy, because we know that mood changes are common in all individuals pregnant, not just those who have epilepsy, but stress during pregnancy, anxiety during pregnancy are common in our population. We've shown that in some of our studies, and that can have negative outcome on mother or child. So working on controlling stress, which can improve your sleep, those are important. There's other things you can't control: stress, sleep. These things are important, and I think we're going to touch on that later. The other thing in terms of tips of sort of to the mother who asked about her child who takes valproic acid, and I'm sure other individuals out there, I think it's important to understand, Allison went over so much information, but that it's sometimes helpful to talk through the numbers a little bit, because I think sometimes when we talk about high risk, people think, oh, it's like like if I get pregnant on valproic acid, I will have a child with malformations, or I will have a child with neurodevelopmental, abnormalities. And it's really important to know that while we're talking about risk, it's relatively small risk when it comes down to it, right? The majority of people who are pregnant and have children born on the medications that we consider higher risk are at higher risk for negative outcomes, but it's certainly not a certainty. So when we talk about the malformations that Alice and Dr. Pack talked about, generally these can happen to any pregnancy about 2 to 3% of the time. When we're talking about children who have been exposed to valproic acid, on average, we're talking about a risk of about 8 to 10%. It can be lower than that at lower doses. It can be higher than that at higher doses, but we're not talking about a risk of 90%. And I think that's sometimes important to just understand. I'd say 10% is a ballpark number. Again, higher doses can go up to 15 to 20%, but that's depends on the study and how you look at it. Also, for neurocognitive development, there are some studies that show that being exposed to valproic acid can result in a lower IQ of about 10 points, but that data on the lower doses, it's not as clear how solid that is. There's definitely no dose at which there's no risk, but the lower doses may have lower risk of negative neurocognitive outcomes. When we talk about autism spectrum disorder, we're talking about risks of about 2% and 4% on some population studies. So I think it's just important for people to understand these are risks. They're risks you have to understand, and that's why we want to plan the pregnancy to reduce risk. But it's definitely not a certainty that getting pregnant on medications we consider higher risk will have a negative outcome.
Thank you for emphasizing that important point. So I know I'm going to hop to Monique here next, but I know when I was going through my pregnancy journey, talking with my doctor to switch medications to get off of those higher risk ones were easy to do, took, just a few months to transfer off those meds and get on a better med and all of that. So having those conversations with your provider is very important to do, because they're there to support you and help you on your journey, which Monique is the question I, want to bring you. Can you tell us more about your pregnancy journey? And, we kind of touched upon this with different, tests that go on. Did you have additional doctor's appointments, or did you have to switch medications? Kind of what did your journey look like from some of what we heard from the providers so far today?
Yeah, absolutely. So I was considered high risk. And so with that being said, I had a doctor's appointment almost every week. I was going to a high risk doctor and my regular OB. And so that they could kind of keep monitoring things. And while I was pregnant, I took my regular prenatal. I don't know if you guys have touched on that, but prenatal was emphasized heavily on there. And my regular Keppra, which is of course one of the safest medications I talked about, which is the long L word I cannot pronounce. But I was on Keppra, and I was they upped my dosage, and I was also on folic acid, and I think iron. I had low iron at that time too. So I was taking about 4 pills, and then I asked if I could have my prenatal as a gummy, just because I was tired of taking so many pills. And they were like, yeah, as long as it has the same ingredients, and it did. And so I was high risk, considered high risk until like the middle of my pregnancy, and then they kind of subsided my regular appointments. And then around my 3rd trimester is when we started going back weekly. One thing they suggested was I have an epidural during pregnancy, or during labor, or during delivery, which was fine by me. No pain. And then also they wanted to induce me if she did not come in a timely manner. They did not want my body to go into any more stress. So she was, I think, due on August 29th. She ended up coming August 19th. So she was 10 days early, so I didn't have to get induced. But that was one thing they wanted to do, was induce me on my actual due date, so that I wouldn't have to go through any more stress. And I do thank God for the epidural, because you don't feel a thing. And yeah, I think that was probably the best choice during that time.
Thank you for sharing more of your journey, and about how, being that empowered patient to ask for that gummy instead of, taking more pill. always important to, speak your mind and share, like, for your peace of mind and everything too. So Dr. Penovich, I want to come over to you. So we've been focusing a lot on someone planning a pregnancy, but as we've touched upon a little bit, and Monique shared with her journey, what if someone learns that they're pregnant and they weren't planning on it? What's the best thing they should do to, have the best pregnancy then in that situation?
Well, not having the luxury of that well thought out plan for how it's going to go. You have to, again, realize that about 50% of those pregnancies are unplanned. And so actually thinking about it when you're not thinking about it is one thing to sort of way to approach the problem. I think, and high on that list is just taking folate from the time that you could potentially become pregnant and then, be that age 14 or 18 or 16 or whatever. Folate should be part of your daily vitamins, and continuing that through pregnancy. So the way I approached this to my young women is we would talk through time beforehand, even long before they thought they were going to do it, was if you find out you're pregnant, right after you tell your folks, you call me. So being in touch with your provider very early on so that you can do those very frequent checks on your blood levels, as Dr. Gerard said, because they're going to change, and sometimes they can change pretty quickly, or they may not do that till the second trimester. But having that done regularly through is very important. And that's particularly true, as was said, with levetiracetam and lamotrigine, but oxcarbazepine is another one for having changes happen very quickly. And then again, remembering at the time of delivery, those medicines that have been increased are going to need to be decreased so that you don't become toxic from the levels getting too high. So you want to stay seizure free if at all possible, whether this pregnancy is planned or unplanned. And you want to do the usual things, which is, as Monique has said, try to stay as stress free as you can, get enough sleep, eat healthily, don't smoke if you can avoid it at all. Avoid alcohol. Be diligent about taking your seizure medications regularly and consistently. Get good exercise and do as much as feels comfortable for you. There are women who've certainly been running in races and marathons well up until their third trimester and even longer. If you have a seizure, don't say, well, I'll tell the doctor next time I see them in 6 weeks. You call the provider then and say, I've had a seizure and maybe we need to get a level a lot quicker than waiting for the next monthly time to happen, because your metabolism could have done a jump. And just as in any planned pregnancy, you should follow up on a regular basis with your OB and follow that list, as well as with your epilepsy providers, to what works for the two of you in setting up your appointments.
And since you mentioned running, I'm going to bring one of our audience questions to you that came in. As a health educator and fitness professional, I am interested in guidelines around physical activity in clients with epilepsy during pregnancy. Are there resources for becoming more educated in this area? Is there anything that we can share with this individual around that? And others can jump in too, but you had mentioned running, so I thought I would bring that.
I've done that from experience with patients, and I don't have any actual references, and I wonder if Dr. Pack does, because they just had the New York Marathon out that way.
I don't have any specific in terms of pregnancy, but I will say that, I looked at this a number of years ago, and there is good data supporting that being active and being physically, active is very helpful. And that, as we've talked, Monique has gone through this so nicely about stress and sleep. Like, physical activity helps with that. It helps with your stress. I can tell you personally, I sleep better when I actually exercise, so it's good. And sleep is good for seizure control. So I think it's, so I would highly advocate that. And I have to be honest, in my own encounters with individuals I treat, I ask every single one of them, tell me about your level of activity. and certainly in pregnancy, because if you're active, as I said, some of those potential triggers, you're probably going to be able to help mediate that. So I'm not aware of any specific resources for that, but I strongly recommend it. And I didn't run the marathon.
I'll add that the Epilepsy Foundation, I know you guys have been updating your website, but there was at one point a really nice overview of exercise and different exercise risk for patients with epilepsy that I use in my own practice. So I think I think it's less about pregnancy. Your OB may give you restrictions about being pregnant. You don't want to start running a marathon for the first time when you're pregnant. But in general, for individuals who are living with epilepsy, there are good kind of benchmarks for which types of exercise might be best for you. So for example, I mean, if you're living with active seizures, right, you don't want to be necessarily on a elevated elliptical machine or a running machine that you can't turn off. So running, walking, floor activities may be more appropriate for you than things like horseback riding or being on a machine or elevated or rock climbing. And I think there's a nice breakdown on the Epilepsy Foundation webpage about if you're thinking about getting active, what are some safer ways to do that if you're living with seizures currently.
And also, I mentioned swimming earlier, but I was with my husband and family members. So if you do have epilepsy, please swim safe. Make sure there's a lifeguard on duty or with someone with you. Just wanted to put that out there.
Having somebody go to exercise with you also makes you keep up your exercise routine too.
Yeah, having that motivation is important from another person too. So thank you all for answering that question. And Dr. Pack, I will come to you as we're, closing in on our time here today, but we can get a few more questions in here. So planning for a postpartum period is important. And we've heard about that when Dr. Penovich was talking about a birth plan. So after the baby is born, what can a woman with epilepsy do to create a supportive and safe environment for them and the new baby?
Allison, thank you for that question. It's so important because, so much, and I'm sure this was your experience, Monique, although I don't want to speak for you. So much of what we talk about is getting through the pregnancy. What is the data? How's my medication going to affect it? How do my seizures affect? How's delivery going to be? And there's really not been a lot of study or focus really on what happens when you're home, you have the baby now. And I really try, Dr. Gerard and I were working together on a program, and we had a lot of discussion about this. And it was interesting getting different perspectives, because I really try in my practice to bring this up very early. And I like the partner or the support team to come to the appointment. How are we, and what I think is really important is to know yourself, know your epilepsy, know what your triggers are, and have a supportive team. So for example, let's talk about sleep. If sleep is a real sleep deprivation is a real trigger for you, I don't necessarily want you being the person up every 2 to 3 hours and not getting sleep. Now, if you're a person who can breastfeed and fall asleep when the baby sleeps, and that works for you during the day, then that may work for you. But if you're somebody, and I can tell you personally, that when I'm up, I'm up. I'm not that person who can doze off. I'm somebody who needs a long stretch of sleep. So if you're somebody who really needs that long stretch of sleep, you're going to need a plan. You're not necessarily going to have to be able to, feed that baby every 2 to 3 hours. So I think, as I said, knowing your triggers, knowing your seizures, knowing your epilepsy, and knowing yourself is really important in this time period. So getting enough sleep, how is that going to happen for you? And very likely you're going to need some support. If you're breastfeeding, we talked already that we encourage that. You may want to supplement one of those feeds either by pumping or using supplemental formula to have somebody else feed to allow you to have that one stretch. So that's sleep is definitely something that's important. Seizure safety, think about that. If you're somebody who is vulnerable, at risk of having seizures, you should not be bathing that baby alone. You should do that with somebody with you. Walking across the room. Dr. Gerard brought up a very good point when we were sitting around talking about this, is those baby carriers. Those are not good for people who have seizures. Don't use those. Have a stroller. Put the baby in the stroller, walk across the room with the stroller. So think about those. So the sleep piece and the safety piece, and surround yourself with individuals in your family and friends, family, or if necessary, hired people if you have the means to help you get through that in the safest way for you and for your baby. And again, for just like pre-pregnancy planning, those issues are best discussed prior to delivery and making sure that you have the support you need that's safe for you and for your baby.
Thank you. That's all extremely helpful. And I want to take a question from the audience that came in, and I'll leave it open to anyone that would like to respond. Myself, as a woman with epilepsy, I had shared we were on a pregnancy journey, but it was unsuccessful just due to some challenges that came through our way. And someone asked, while I'd like to keep things positive, miscarriage can happen to anyone. If this were to happen, is there anything women with epilepsy need to watch out for specifically? So I wanted to make sure to ask that and bring that question to the group.
Well, the risk of miscarriage in women with epilepsy is really not significantly higher than the general population. And it surprised me actually when I was delving into this as to how high the risk is, particularly for the first pregnancy. It can be up to 25% of first pregnancies can miscarry. So there really doesn't seem to be any more risk. The issue is if you have a generalized seizure that causes you to fall and have blunt trauma to your abdomen and your organs, then you've placed maybe that pregnancy at risk because of that. But that's different than just a routine miscarriage.
Dr.
Yeah, I agree. I agree with what Dr. Penovich said, and I think in general, especially early miscarriages, they're really common. It's like one third of pregnancies, and I think one thing people don't realize enough until they've been through it is if you actually start talking to people, you'll find lots of other friends, not necessarily with epilepsy, who've been through it, and it's still a loss. It's still really, really hard. In addition to obviously just safety concerns, the same things that we do postpartum that Dr. Penovich talked about before, we also have to do after a miscarriage. So we've talked about how we adjust your medications during pregnancy, and after pregnancy, we give you this postpartum plan, or your doctor should give you a postpartum plan that tells you how to adjust your doses back down. So depending on how early the miscarriage occurred, you may have increased your doses during that pregnancy. So you certainly need to let your neurologist know that you have miscarried. And then from there, get a plan for how you're going to adjust your doses back down. When this happens to my patients, I usually keep them on the slightly higher dose for about 2 weeks. I might give them a little something else maybe to help sleep for a few days. But before they start to try again, I want to make sure they're back down on the dose that they conceived on, because again, we want that conception to happen at the lowest dose. I think those are the main points. Allison, did you have anything you want to add to that? Or?
Yeah, I was going to say that covered the main questions that came in, and then Dr. Pack, because I know there's two Allisons on the webinar.
I'm so sorry, and I'm
fine.
trying to call her Dr. Pack, but I've known her for so long. It's hard.
No, Allison is fine.
I want to say something because Dr. Gerard brought this up about before she tries to conceive again. And I think it's really important for women with epilepsy to know that their fertility doesn't appear to be any different than the general population. So the ability to become pregnant is not affected by your epilepsy per se.
Dr. Pack, anything to add to that question?
No, I think all those, just great points from Dr. Penovich and Gerard. Yeah, really good points. And to reiterate, miscarriage is unfortunately very common. And, you know, I've taken many individuals through multiple pregnancies. And, you know, I want to encourage people that if that's your experience, you very likely will go on. As Dr. Penovich just said, fertility is not necessarily, has not been shown, particularly with the newer generation medications, to be affected in individuals with epilepsy. And I definitely, very fortunately, have seen individuals have miscarriages and go on and have normal, healthy babies thereafter. So that's the, you're right, the negative, but there's the positive piece of that as well.
You know, I think the other thing that several of us have said in our little pieces have mentioned anxiety and depression, and that happens during the pregnancy itself. It can happen in the postpartum time as well, and we know that those things happen at increased risk in folks with epilepsy in general. So I think it's important to be aware of that for yourself as an individual, and to have discussions with your physician or to have a therapist, and to particularly be watching for that postpartum increased in anxiety and depression when you're at risk, just because you may be sleep deprived and stressed out as well. You know, when you've had a baby, those of us who have, we also know that you get that baby brain phenomena where it's like, do I have a brain? How am I thinking? And that can make you feel more anxious and depressed as well. In a particular time, then, to even be more vigilant about having your medicine box set up, so that, did I take my medicine? Oh yeah, I guess I did, or no, I didn't.
I just had I see that there was a follow-on question to the same topic, so I just wanted to tag that on before we move on. I think the question is, can we expect seizure to happen after a miscarriage? And I would say, having taken care of many individuals who have had these miscarriages that we speak of, because they are common, in general, no. Seizures don't necessarily worsen or increase just because of a miscarriage. Of course, there are hormonal changes. Of course, there's going to be stress and sleep deprivation, and we should try to address those. But in general, I don't see, it hasn't been formally studied, but in general, I don't see miscarriages triggering seizures. And so I don't think that should be an added worry. As I said, I sometimes give like a little bit of clonazepam to people the first couple nights, particularly if they've had a procedure. That's just my style, to help them sleep. But in general, I don't think that's a concern.
Thank you for covering that last question. I didn't see that one sneak in there. But we're just at our time here, but I wanted to just give everyone a minute here. And if you have like a last tip for any of the new moms or future moms or anyone that might be listening, we can start with Monique. I saw you smiling and nodding along with some of the comments that were being made. So we can start with you. Any last tips for anyone that's listening today?
Routine. That is what got me through, and that's what keeps me going now. My daughter's now 7, and we are on a routine. And it started the day we got home from the hospital. I did have a support system in place. I thank God my mother-in-law is a labor and delivery nurse. So she was able to kind of take over some of the shifts. I was able to breastfeed up until 13 months. When I decided to go back to work. But I woke her up. They say don't wake a sleeping baby. No, she woke up every 3 hours. We fed. My husband did a diaper change, and then we went back to sleep. And then we did it every 4 hours, and by the time she hit 4 months, we were on a routine. We also were on the same level. We have a 2-story home. At that time, we had a 2-story home. So we were all in the living room. We all slept on the couch, and she slept in her bassinet, and she was just close by. So I didn't have to go upstairs and get any materials. We had diapers. Whatever we needed right there. The kitchen was right there. If we needed food, so that way we weren't going all over, and we were able to kind of have a system in place. And then after a while, when the support kind of left, like when my husband had to go back to work, my mother-in-law had to go back to work, I had my own routine that she was already kind of in place, so that she slept when I slept. I slept when she slept. And if I didn't get laundry done that day, it just didn't get done. If I didn't cook, we had McDonald's. It is what it is. You'd rather be healthy than have a clean house during that time so you don't have your increase of seizures. And I still to this day keep a routine for her and for myself and my husband, just because I still do have epilepsy, even though she's older, just so that she goes to bed at a certain time. So me and my husband can have a certain amount of time together. I can get schoolwork done and I'm not overwhelmed, and just having that time management to keep everything in place. So I definitely tell all new moms, even if you don't have epilepsy, have a routine in place so you don't feel so out of it. You will still be out of it. Oh, don't get me wrong, but it won't feel as much if you keep that routine in place and you keep a timer so you know, oh, okay, it's 3:30, time to feed, time to change a diaper. And every now and then you might have to pivot, but I definitely kept a routine from the time she came home and to now.
I see everyone smiling, so I think they would agree with that tip, and I see not. So I think that's just a good life tip too, that routine. So thank you. Anyone else? Last tips for any of our listeners? Dr. Pack, I see you in.
Just, my only thought is that, and Dr. Gerard kind of alluded to this earlier. I think if you leave with anything, most individuals getting pregnant who have epilepsy, take anti-seizure medications, have normal, healthy babies. And if you leave with nothing, leave with that. And recognize that work with providers, work with your family to provide the best environment for your developing baby and for you and your child after the baby is born. And that's really, just have a good team on your side. That's it.
Wonderful advice. Dr. Gerard or Dr. Penovich?
There were some questions in the chat. I was just trying to tap the answer about having neurostimulation like an RNS or having a epilepsy surgery, how that would affect plans. And I'd say that most of what we said here would just apply just as similarly. We don't expect anything negative after having surgery or having a neurostimulation for pregnancy. The idea behind those procedures is to offer better seizure control. In some individuals, that might mean reducing or adjusting your doses to lower doses or healthier or safer medications. But for the most part, most patients still need to continue on medications, even with an RNS and often after surgery. So it would definitely be something to talk to your doctor about, not just to stop medications.
All right. Thank you for capturing those. I appreciate it.
Yeah.
So my final tips would be to enjoy this youngster that you've brought into life successfully, as we've noticed, for 90% of the time, and remember that significant other helped create that baby and can help take care of that baby as well, and have fun.
All wonderful tips. Thank you. And let me just close this out real quick here. So I just want to, thank you all so much for joining this discussion and for your support of the Epilepsy Foundation's mission. I'd like to thank Drs. Pack, Penovich, Gerard, and Monique for joining us and sharing their expertise with us throughout this past hour. And I'd also like to thank again our webinar sponsor, UCB, for sponsoring this webinar and for hosting it during National Epilepsy Awareness Month. Lastly, I just wanted to share, as always, you can reach out to the Epilepsy Foundation 24 hours a day, 7 days a week through our helpline. The numbers are on the slide and available in English and Spanish, or you can email us at contactus@epilepsy.com. So thank you all for joining us this afternoon, and I hope you have a wonderful rest of your day.